We're bypassing the pleasantries today to execute a rapid-fire clinical simulation. We're dissecting the absolute highest yield diagnostic boundaries and resuscitative thresholds for neonatal jaundice and hepatic failure. If you're targeting that top-tier 270-plus clinical performance, mastering these discrete management steps and intricate mechanisms isn't just helpful, it's absolutely essential. So let's jump straight into the clinical material. Right out of the gate, we have to isolate the absolute chronological boundary. Now, we know unconjugated or indirect hyperbilirubinemia is incredibly common. It's usually just due to immature hepatic UGT1A1 enzyme activity combined with high red blood cell turnover. But here's the catch. Timing is literally everything. Unconjugated hyperbilirubinemia presenting within the first 24 hours of life is strictly pathological. Every single time. It's overwhelmingly driven by hemolytic disease of the newborn, typically your ABO or RH incompatibility. Let's look at a concrete integrated assessment. We have a neonate born to a blood group O mother, presenting with profound jaundice in the first 20 hours of life. This specific clinical presentation instantly establishes a diagnostic triad for us. We're looking at a rapidly rising indirect bilirubin, a positive direct Coombs test, or DAT, and reticulocytosis. That exact triad is highly consistent with ABO incompatibility. When we systematically dismantle the 5 answer choices here, we immediately rule out breast milk jaundice. Why? Because of that early onset. We also bypass G6PD deficiency since the maternal-fetal blood type mismatch points overwhelmingly to immune-mediated destruction. What's happening is maternal IgG antibodies are crossing the placenta and attacking the newborn's erythrocytes. Because these antibodies strictly target red blood cells, the leukocyte and platelet lines remain completely unaffected, so cross off options B and C. Options D and E are also incorrect. In the setting of active hemolysis and limited conjugation capacity, serum indirect bilirubin would be massively elevated, not decreased. Therefore, these maternal IgG antibodies strictly result in a decreased hematocrit due to active hemolysis. Option A is our only correct answer. If we put these presentations side by side, it perfectly isolates conditions that might look superficially identical, but they diverge critically on 2 things: chronological onset and direct antiglobulin testing. Breast milk jaundice, which we theorize is caused by an enzyme in the mother's milk, always presents later and is DAT negative. This clinical variance proves, without a doubt, that indirect hyperbilirubinemia in those very first hours of life mandates an immediate hemolytic evaluation. Okay, let's shift gears a bit. We must transition our thinking from unconjugated excess to the direct bilirubin threat. Sure, unconjugated hyperbilirubinemia can be physiologic later in the first week, but conjugated hyperbilirubinemia, specifically when it exceeds 10% of the total bilirubin, that unequivocally indicates a pathologic hepatobiliary process. Let me be clear. Conjugated hyperbilirubinemia is never physiologic. It is never normal. So, what's the most critical conjugated bilirubin pathology you need to identify? Biliary atresia. The underlying mechanism here is essential to understand. It's an idiopathic, progressive, fibro-obliterative destruction of the extrahepatic biliary tree. Because this destruction completely blocks bile passage into the duodenum, these infants classically present right between 2 to 8 weeks of life. You'll see severe fat malabsorption, pale or acholic stools, distinctly dark urine, and hepatomegaly. If this goes unrecognized, it rapidly progresses to irreversible cirrhosis. To manage this correctly, you must follow a very strict diagnostic sequence. The absolute first imaging step is always a right upper quadrant ultrasound to look for an absent or abnormal gallbladder. Now, if that's equivocal, you follow it up with hepatobiliary scintigraphy, a HIDA scan, which will demonstrate a complete failure of tracer excretion into the small bowel. But remember, the definitive diagnostic gold standard, the test that actually confirms the atretic ducts, is the intraoperative cholangiogram. The surgical kinetics for this condition are absolutely critical. Honestly, time is tissue in the liver. Performing a Kasai hepatoportoenterostomy strictly before 8 weeks of life is an absolute must to reestablish bile flow. Delaying intervention beyond that tight 8-week chronological threshold guarantees irreversible biliary cirrhosis. At that point, a liver transplant becomes the only remaining definitive option. Analyzing our next integrated assessment, we're faced with a thriving 6-week-old boy who is exhibiting diffuse jaundice and a direct bilirubin of 5.2 milligrams per deciliter. This is a definitive obstructive pathology, which completely rules out any sort of enzymatic immaturity. We have to act on this immediately. This scenario brilliantly illustrates why we need strict management protocols. Looking at our 5 options, the matrix forces us to select option D, ultrasonography of the abdomen, as the initial imaging step. We exhaustively rule out options A and B, phototherapy and exchange transfusion. Those modalities are exclusively reserved for unconjugated bilirubinemia, so they offer zero benefit in this case. Furthermore, we definitively reject option C, switching to a cow milk formula, for an infant with adequate growth parameters. And option E? Absolutely not. You don't just stop management for a primary hepatobiliary obstruction. Isolating the singular biochemical variables here precisely separates these two entities. A self-resolving, benign physiologic jaundice clears up quickly, features normal stools, and shows an unconjugated bilirubin profile. In stark contrast, a fatal fibro-obliterative disease like biliary atresia persists well beyond 2 weeks. It presents with those classic acolic stools and features a conjugated bilirubin profile that requires emergent surgical intervention. Now, progressing to the ultimate neurological emergency, kernicterus. Unbound, unconjugated bilirubin is highly lipid-soluble. When the body's bilirubin load exceeds its albumin binding capacity, that free bilirubin basically operates as a severe neurotoxin. It easily permeates the immature blood-brain barrier, causing irreversible deposition and destruction, specifically targeting the basal ganglia, the pons, and the cerebellum. You need to know that acute bilirubin encephalopathy does not manifest subtly. It presents with discrete, rapidly escalating markers. As a clinician, you must immediately recognize the transition from initial lethargy and hypotonia to severe hypertonia. You'll hear a very distinct, high-pitched cry, and you'll see the classic posturing of retrocollis and opisthotonos, which is that severe, rigid back arching. For high unconjugated levels, phototherapy is typically our first line of defense, as it converts that bilirubin into water-soluble lumorubin for urinary excretion. However, and this is a massive however, a rapidly rising level that crosses the 20 to 25 milligrams per deciliter threshold establishes an absolute resuscitative mandate. At that point, you need an emergent exchange transfusion to mechanically remove that bilirubin load from the blood. Let's look at this final, highly severe assessment. We have a preterm neonate born at 36 weeks gestation, presenting to the ED with a massive total bilirubin load of 28 milligrams per deciliter. But more critically, this infant is exhibiting overt, profound neurological deficits, a high-pitched cry, retrocollis, and opisthonos. This is frankly diagnostic of active kernicterus. An exhaustive analysis of these 5 choices dictates that you must completely bypass option 1, which is initiating phototherapy only. The correct action is option 2, an emergent exchange transfusion to mechanically remove that neurotoxin right out of the intravascular space. Option 3, IVIG, is completely ineffective as a primary intervention for this degree of profound encephalopathy. Option 4, starting a lumbar puncture and ampicillin, is an unnecessary delay for a sepsis protocol when the diagnosis of kernicterus is staring you right in the face. And option 5, reassurance, that is just dangerously negligent. Do not fall for the clinical trap of stepwise management when it comes to acute bilirubin encephalopathy. The presence of any established neurological sign completely invalidates conservative therapy. Initiating phototherapy here would be a catastrophic delay of care. You must initiate immediate mechanical blood exchange to prevent permanent basal ganglia destruction. Mastery of these discrete thresholds is exactly what separates basic competent management from truly exceptional clinical practice. That covers the simulation. Keep these parameters locked in, and you will be fully prepared.